This is Pat Walter, and today is November 13th, and we're interviewing Dr. Gross for the Surface Hippie website. Hi, Dr. Gross.
Hello, Pat. Thanks for coming to Columbia to see me.
You're welcome. Can you tell us, when did you start doing hip resurfacing?
I believe it was 1999, so it's been 9 years.
And why did it interest you?
I was always interested in the most challenging group of patients for hip arthroplasty, and that was the young active patient. Back then we really didn't have a good solution for the young patient. At the time I was using uncemented implants with ceramic plastic bearings and using custom implants, and that in my mind was the state of the art at the time, the best that we could do. But we were still looking for something better, and I came across the concept of metal hip resurfacing at that time at one of the Orthopedic Academy meetings. And at that time we were just, the idea of metal bearings were just coming back. You know, they'd been used back in the 50s but had been unsuccessful, and we'd gone to using metal plastic bearings over all these years, and then we evolved into ceramic on plastic bearings as the highest end type, the best type of bearings that we had in the early 90s, in my opinion. And then this metal concept came back again, and it allowed us looking at resurfacing again. It had been a disaster with metal plastic bearings, but with the new metal bearings it was surfacing again, and it seemed like a very interesting concept, and that's when I started looking at it and started using it.
What are the most common reasons that both men and then women need a hip resurfacing? For instance, CAM, FAI for men. Can you explain that?
Yes, most people particularly people who have arthritis at an early age we're recognizing more and more have underlying deformities of their hip that leads to early arthritis. We're learning a lot about this. We've learned a lot in the last 10 years. Reinhold Ganz in Switzerland has been one of the pioneers in teaching us about this. We used to think that most people who got hip arthritis, it was just osteoarthritis, and we didn't really know why they went bad. But we're learning now that we've always known about hip dysplasia, but that's more common in women. It's a particular set of deformities, and it's probably the most common reason that I see young women who need hip resurfacing, some type of hip replacement, and I do resurfacing, of course. It's far less common in men, but about 2/3 of young patients that need a replacement are men, actually. They have a different deformity, and it's typically cam femoral acetabular impingement. I would say 80% of young men that I do resurfacing on have that deformity. It's a complex shape deformity. The head is not sitting exactly right on the neck, and it leads to higher stresses in the socket and earlier breakdown of the cartilage. It's a mechanical problem. I don't think those people have naturally weak or bad cartilage, or that they are victims of trauma or anything like that. It's just that they have a deformity that puts extra pressure on their cartilage in the socket. That's the easiest way to explain it. And so the cartilage breaks down early, and by the time they come to us, to doctors, with problems, they've lost their cartilage. So you can't just correct the deformity anymore in most of those people. At least when I see them, they've already lost cartilage, and then you have to do some type of replacement, and I think resurfacing is the best option, of course, for those people.
Can you explain, you do the cementless hip resurfacing. Can you explain, for instance, the difference in the femur cup than a regular hip device? Why is it different for your cementless device?
Okay, that's a very good question, and yes, I've been interested in using cementless fixation of all implants. Let's just take a step backwards so we give people some basic background information. Implants can basically be fixed to bone by cementing them. It's methyl methacrylate, it's an acrylic cement, and we mix that up in the operating room, and it acts like a grout, and it goes into the bone, and it locks the implant into the bone as it hardens over about 15 minutes in the operating room. The other way to attach implants to bone is to apply them very tightly to the bone, basically wedge them on, but they also have to have some kind of a roughened, or we call it a porous surface, for the bone to then grow into. So in that second method, they're initially fixed by wedging, but if they didn't have the porous surface, they would, after 6 months, a year or two, they'd come loose and it'd be painful again. So an implant that moves against bone is painful, and we learned that back in the 50s and 60s. So then cement solved that problem, but then cement is not extremely durable in most applications, attaching implants to bone. So for elderly patients early on, it seemed like a really good solution, but then as we learned more and had longer follow-up, we learned that the cement started to break down. It was a weak link and it fatigued. So we've developed a number of different surfaces that are uncemented or porous ingrowth, and so that the bone then grows into the pores of the implant. So then again, there's an interdigitation, mechanical, between the implant and the bone when all is said and done, and that holds the implant fixed. So there's those two ways of attaching implants. How does it apply to resurfacing? In hip resurfacing, the socket component has always basically been uncemented. By the time the metal-metal resurfacing came around in the early 90s, when the first experiments were being done with these, it was by that time we already knew that uncemented sockets worked better for total hip replacement, and although there were some early trials with cement on the socket, they were quickly abandoned. We realized that porous ingrowth fixation, this is just one type of porous coating. This is a plasma spray titanium roughened surface here where the bone can grow into, and there's probably about 5 or 10 different types of surfaces that all work very well. So certainly over the last 10 years, all resurfacings are metal on metal bearings, and they employ a bone ingrowth surface for the socket. On the femoral side, on the other hand, the surface of choice has been cement, and so typically what you do there is you just have this just what we call a grit blast surface. This is cobalt chrome, the implant. They all are cobalt chrome, and there's just the inside's a little bit roughened, but it's like a very fine sandpaper, and the cement can interdigitate with that very well, and the cement then goes into the bone and grips onto the bone. You might ask, why did we use cement here and uncemented here? The first companies that started making hip resurfacing, I believe, didn't have the ability to put a porous coating on the inside of a component. See, it's a lot easier to spray one of these coatings on the outside. You can see very easily why that would be so. But to apply it on the inside is a much more difficult problem. So early on, they didn't pursue that problem, and they just said, well, they tried cement, it seemed to work, and so they just went with cement as a way of fixation. But already at that time, it was becoming clear that in young patients with total hip replacement, that cement didn't work very well for the socket, and even for the stem. Uncemented was already beginning to show superiority, and I think now we can almost unequivocally say that uncemented fixation in total hips, stems and cups, total hips, is better for the young patient. That was my philosophy back in the early 90s when I was doing hip replacement in young patients, and then when I started doing resurfacing, it just didn't make sense to me to go back to using cement in young people. We're putting these implants in young people, and I wanted to develop an uncemented one. But the companies making them at that time told me they couldn't make uncemented components, so it's been a long road to get an uncemented component. It's taken about 6 years to get to that point. During that time, we've also had longer results come in for the hip resurfacing, and turns out the cement has worked tremendously well in the young patients. So you might ask, well, why not just forget about going with uncemented? Let's just stick with the cement. That's worked well. Well, we have 8 to 10 year follow-up, and we're really putting these implants in young people who are extremely active, and we're hoping to build an implant that's going to last 20, 30, 40 years with extreme activity levels. So we really don't have the information we need yet on cement. Is it going to last 40 years? So I'm still pushing ahead with uncemented, and we're in the very early stages of that. I now have an implant that I've been using that has that same kind of porous coating on the inside of the femur. So now we've just roughened that inside, and now the bone can grow into that. This is the same type of titanium plasma spray that you have on the outside of the socket. And I've been using this now for about 1.5 years, and it's going to take a lot of time before we have long enough follow-up to really know if this is going to be a reliable and durable way of attaching the implant. But on a theoretical ground, it just is logical to me to apply uncemented technology to the young active patient rather than have cement in the mix, because I think that's going to potentially break down over time. There are 2 challenges with making an uncemented femoral component. The first is just getting the porous coating applied to this inner surface and having it done in a uniform fashion. If it's thicker and thinner in different areas, then it's hard to design instruments that are going to cut the bone precisely to implant this. So the manufacturer has to be able to really put on this layer precisely and reproducibly. The other thing is you have to have an instrumentation set that cuts the bone very precisely and reproducibly, and then you have to put the two together. So that's what it's really required to develop this, and it seems to work. When we're implanting these fit very tightly, but again, we don't have long enough data yet to say if the concept is truly going to be an advantage or not.
How many have you done to date?
Around 400.
And what has the outcome been to date?
At this point, it's too early to tell about fixation, but we've had no fixation failures. But we have about 80 patients with 1-year follow-up so far, and they look good, but it's going to take at least 2 years of follow-up on x-ray to know with 95% certainty that the implants are well fixed to the bone. It just takes that long for it to show up on x-ray if it's loose, if it's not attached, and to be fairly certain about it. I've had 3 femoral neck fractures, so those are the complications on the femoral side. So it's about a 1% rate, which is the same as my rate with the cemented component. So I had actually hoped that because you're not having the cement that heats up and burns the bone, that we might have less fractures, but so far that's not proven to be the case. So we're still watching these over longer time to see if the fixation is going to be 99%, 100%, or some number below that. That's really what we need to know after 2 years. What's the rate of attachment of these implants? And if they have a very high rate of attachment, then I think we could speculate with good certainty that they're going to be more durable than the cemented ones, if they attach. That's the whole question. At what rate are they going to attach to bone? On the socket side, by the way, 99% of sockets attach to bone. It's a very reliable process. And so we're hoping the same applies to the femur, but we don't have enough follow-up yet to say that for sure.
Let's talk about the future.
Okay.
What do you see from where you sit? What type of changes will we see in devices or even techniques to do resurfacing?
There are a lot of interesting concepts that are coming up at the hip resurfacing meeting, and it's not clear how many of these are going to turn out to be improvements and not. I've come across, for instance, ceramic surfaces in hip resurfacing, and I know they're being developed primarily in Europe. And they're interesting because they get rid of this whole issue of metal ions being released in the body, because ceramic is more inert, and ceramic particles will be released, but they seem to be theoretically less of a problem. But the downside, of course, with the ceramics are inherently more brittle than metal. So if you're putting these in young people who are going to run and jump on them, you know, if you slam ceramic surfaces together, they may eventually just fracture. These cobalt chrome bearings, of course, it's impossible to fracture them. You can slam them together as much as you want, they would never break. So that's going to take a really long-term study to see if they're going to be able to hold up if they ever come out, and are they going to be able to remember, these have to be very thin surfaces, so they have to have a thin ceramic, a very brittle material. They're getting better with making ceramics that are tougher, and then they have to have some way of applying a bone ingrowth surface. Certainly on the socket, it's absolutely mandatory. So, you know, how are you going to attach a bone ingrowth surface to ceramic? You almost have to have a ceramic layer, a metal layer, and then the bone ingrowth layer. Those are challenges. And on the femoral side, you know, if uncemented turns out to be superior there, then we have to also be able to apply a bone ingrowth surface to a ceramic head. So there are a number of challenges. It's going to be many years before we know if that's going to be an advance or not. I think one of the other very interesting things that's being developed now are different ways to more accurately implant these devices. Particularly on the socket side, it's becoming more and more apparent over time that the exact position you put the socket in is probably even more important than the femoral component. At this point, we have very little data about the best position to put the socket, and the reason is because we have very inaccurate ways to put them in. It's just the eyeball of the surgeon, basically. Now we have navigation also, which is starting to be used, but the problem with navigation is you have to register the points with this pointer, and that introduces a lot of inaccuracy in the system. There are some new systems coming out now where the whole thing can be based on three-dimensional CT data, and I'm very interested in that. I think there's a potential for for planning the surgery three-dimensionally and then developing a way to execute that plan using the three-dimensional data. So I think that's really promising. The problem is it's all terribly expensive to do this. It's going to probably add several $1,000s to the cost of doing this procedure. And in today's healthcare environment, I don't know if we can go there. It's going to be a difficult challenge. But first of all, measuring exactly where these components are three-dimensional with CTs would be a start in the right direction, because we just have x-rays right now and they're terribly inaccurate. And so we're making judgments on how well implants are placed by x-rays, which are 10 to 20% inaccuracies. So it's very tough to draw good conclusions. So we need to learn a lot more about precise positioning of these implants, and there's technology coming on that's going to allow us to learn more about that and then come up with better guidelines on how to place it, and maybe even use three-dimensional data to place these implants better. But again, the expense is going to be the big downside factor there. It's going to cost a lot of money to go there.
Well, Dr. Gross, thank you very much for taking time to talk with us, and I know hundreds and hundreds of future patients will be watching your video and learning, and I know they're interested in the cementless technique.
Thank you very much, and thanks again for coming, Pat.
Thanks. Bye-bye.